so let's get started. Welcome everyone, and thank you for being here today for this session of the New Mexico Primary Care Training Consortium Faculty and Staff Development Series. Our topic for today is exploring the STFM CBME Toolkit and Direct Observation Tools. Just a note, if you have not already, it would be helpful to get a copy of your active assessment using direct observation form, which you may already have in your new innovations. If not, we do have that copy to be posted. Oh, it is posted in the chat to use as an example. Other than that, I'd like to go ahead and welcome Dr. Rae Wright. Thank you for being here with us. We can go ahead and I think stop share screen, and I'm going to read her bio for you all. Rae grew up in rural Eastern Kentucky and graduated from the University of Kentucky College of Medicine in 1990 and completed her family medicine residency in Ventura, California. She is boarded in both family medicine and addiction medicine. She has worked with the WWAMI Family Medicine Network Faculty Development Fellowship on curriculum development for 15 years and currently serves as the Associate Director for the fellowship, which serves over 30 programs in the Northwest. She also served as the Associate Program Director at Peace Health Southwest Family Medicine Residency Program for over 15 years and remains the Addiction Medicine Fellowship Director for this program. More recently, Rae was named to the STFM Taskforce for Competency-Based Medical Education with funding from the ABFM. She spearheads this group's efforts in the development of assessment strategies to meet the new ACGME and ABFM requirements. With that, Dr. Wright, feel free to take it away if you're able to share your screen and share your slides with us.
Okay. Let's see here. Okay. Are you seeing the slideshow now?
Looks good on this end.
Okay. Yeah, so I'm Rae. I actually, as of a week, am now the program director at my old program as well. So basically, I'm the kind of person who can't say no very well. So you probably recognize that person in yourself a little bit. We're going to talk today a lot about what the task force is doing. It's a group of family medicine docs who have been active in all kinds of different things for STFM and sort of all ended up in the same place at the same time and have been working really hard this year developing things. So we want to show you what's in there, and because I think some of it's kind of dug in, and I think it'd be useful to walk you through that. And then we're going to talk about an assessment strategy for direct observation. So our objectives by the end of this is that you can effectively utilize those tools in what's called the STFM CBME Toolkit, and that you'll be able to integrate direct observation into the workflow at your program using a mobile app, and that you'll be able to use data from the tools that we're going to discuss to generate outcomes-based reports, as I'm hoping everyone's aware of now as a new requirement from ABFM. So let's just kind of dive right in and go directly to the toolkit, and then we'll walk through that together. So you can either just go directly to, you can Google STFM CBME Toolkit and find it that way, or you can use the link here, or you can use the QR code. And I'm going to use the link and take us to it from my end. All right. So this is this is available. You don't have to be an STFM member to use it. Any faculty or resident can access this site without membership. So that's the first thing to know. And then we're just going to kind of go through the various buttons. If we start with getting started with CBME, then you come to this page. And the important thing to know about this, is everybody seeing did it go to the next page for the group as well? Yeah. Are these one-pagers about implementing CBME. So for example, there's one on coaching, and it's one page that kind of gives you a resource that you can go to through the American Medical Association for coaching, and then gives just some pearls. So that's a good one-stop shopping to kind of get links to other things for those various topics there. And then are we all back on the same homepage together now? Yep. All right. So this national recommendations for implementation, that's still being developed by the task force. That's one of those things that has gone back and forth with ABFM, our funding source, and before it's going to get finally published, but that's okay. So the next part I'd like to dive into is this core outcomes for competencies and milestones. And then if we go to this, there's several resources I think you'll find useful. The beginning page has all the different outcomes, the 15 outcomes that are required. The first 5, all programs had to report on at the end of last academic year. The next 1 through 10, all programs will have to report on for the graduating class in 2025. And then by 2026, we'll have to be reporting on all 15. So it's a lot. And it's just important to develop strategies as we go to be able to address that. If we click on these individually, you can look at the ACGME competencies, the subcompetencies, and the milestones, which you're familiar with. But what I'd like to focus on here is this idea of mapping. And so what this is this takes all the 15 outcomes here on the left-hand side, and then all of the subcompetencies across the top. And this is what we were tasked with doing, which is to say, at a level 4, which of the subcompetencies map to all these outcomes. So for example, for outcome number 2, diagnose and manage acute illness and injury for people of all ages in the emergency room or hospital. The CCC could correlate that to patient care number 1, patient care number 4, medical knowledge number 2, et cetera, going across the screen. And then when you're trying to get evidence to see whether or not your residents are meeting full competency for that particular outcome, then you can say, well, they need to be at a level 4 in all of these. Now, again, it's not required. It's just one piece of information. If they're not at level 4, it doesn't mean you can't graduate them, but it does give you an option as they're progressing towards that, if they're not on target, to say, hey, these are the milestones and these subcompetencies that you should be working on. And then it also just gives you some leverage when discussing this with the residents, especially the third-year residents about halfway through the year. If they're not close to a level 4, then that gives you a framework for discussion. Any questions about that issue? Okay. So again, the mapping is not a graduation benchmark or requirement. It's just a tool that ABFM asked us to come up with to help give residency programs some kind of reference. So if we go back to the tool page, the next thing I'd like for us to look at is the assessment tools and strategies. And on this, there's some just basic recommendations for using the CBME tools, some guidelines for program directors, the ACGME family medicine requirements for competence, again, referring back to those outcomes. But on this first part of this, what I think is most important is the ACGME assessment guidebook. So if you've never seen this before, this is a great resource that's on the ACGME site that a lot of people haven't seen. And this is, again, directly from ACGME. And it goes through all these different kinds of assessments. It gives you examples. It divides them up in what they recommend is best for different competencies. It's just a wealth of really great information about assessment. It's also a great way if you want to make your own faculty development slideshow. There's fantastic information found within this as a reference for your CCC or anyone who's trying to develop evaluation tools for whether it be an individual area of curriculum or whatever you're trying to work on. So that I would highly encourage you to go back and look at more. Next here, you see what an entrustment scale is. We're going to talk a little bit about more of that today. Then I'm going to click on this button here where it says direct observation mobile apps. So the evaluation tool that we're going to focus on a little bit extra today is called the active assessment using direct observation. And then this tells you how if you haven't already set it up in your program to use on your phone, this is all the instructions for doing that for new innovations. And then if you're a MedHub user, is everybody here new innovations user or MedHub user? Anybody not a new innovations user?
I think today it's mostly new innovations.
Okay. New Innovations, I have to say, works a lot better. They sort of just went all in to do this, and now I think that they're being rewarded by other specialties or picking up the same thing. So we're going to walk through in detail what this thing can do. The next thing that's important is just CBME assessments, and this is something that the task force spent a lot of time on. It's called the Outcome Assessment Starter Pack. So if you click on this, it looks like this, and it has some commonly used assessment tools with hyperlinks. These are ones that were recommended in that assessment guidebook that we looked at. So it gives you automatic links to those. It also takes you to the part of new innovations where a lot of other different kinds of evaluations are already made that you can edit to use how you want. And then this table is kind of the meat of it, and it shows that each of the outcomes, so this one is outcome number 1 in green. It shows you which of those subcompetencies, when we looked on that map, are related to that outcome. It goes through the ACGME program requirements that are related to that outcome, so you just can use that as a quick reference. And then it on the far side, it talks about various assessment tools that you might consider using. Again, these aren't required, but it just gives your CCC some options to think of, and then you can pick and choose from those which ones that work for your program, especially ones that you already happen to be using ideally, or if you're looking to develop more, then this gives you, again, a framework for what more might look like to you. And then most of these have links somewhere else, either above or as we go below. These are the ones that are all in new innovations now as examples that you can use in your program, and you can edit them to make them more to your liking. They're just very basic to start with. Any questions about that? So if we go back, the next of the individualized learning plans. So if you like the IOP that you're using, that's great. If you decide you want to use something different, then STFM has made a template for you to use. This template actually, one advantage of it is that you can use it within the STFM website. Again, nobody has to be a member. It doesn't store the information in a way that's discoverable, but the resident themselves would create their own account, and then they would be able to use this particular template. It also has talking points about ILPs for coaches. It's designed around this template, but it's actually got great points for any ILP. And so this is just a lot of different resources, including some published papers and other resources for your individual learning plans. I see there might be some chat. Okay. All right, so that's the section on ILPs. We go back again to the homepage. The pilot project right now, STFM's has 32 programs engaged in a pilot to use all these tools. And so it's giving us an opportunity to update them. So these are being continuously updated. What you see right now will be better probably every 6 months as we get feedback. There's also a list of in-person faculty development opportunities around competency-based medical education. There's the faculty development webinar series, and this has links to that list. And then ACGME has what's called plug and play didactic presentations that are done by ACGME. And so there's a list of those that you can link to as well. So that's basically what we have been working on and are continuing to work on for the next year. And we really want this to be useful. And so we'd appreciate any feedback you have about those particular tools. And I'm going to go back to the slideshow. Okay. All right, so I'm just going to keep going and then, but just again, just wanted to make sure that you could fully access those tools. And if you have any questions later on about that, I'm always reachable. So I know you had a recent faculty development session about assessments and evaluations. And so I'm not going to repeat all of that, but I did try to take a look at what you were presented and to build on that a little bit. So the various types of assessment tools that you probably use in your program most are global ratings, which are those end of rotation evaluations, the summative evaluations. And I know you talked about the difference in summative and formative being better. And so as we go down this list, we get more into the formative, and really the ultimate formative evaluation is the focused direct observation. So why do we care so much about direct observation? And not only is it because that it is related to formative feedback and formative assessment, but why is formative assessment so helpful as well? And again, the idea that it's much more objective. If you watch somebody do something in real time and you immediately give them feedback, then you can start with saying what you actually observed. So you can use objective language. You're not inferring anything from what they've told you. You actually watch them do it, which also minimizes bias, which is important. It also gives you an opportunity to incorporate teaching. It's meant to be a back and forth. It's not just an evaluation that they look at later like their report card. It actually is you're giving them feedback by what you just saw them do, and they're responding to that so that you can really focus on whether or not they're where they are in their competency journey for whatever you watch them do. So another reason that we look at it is this is something called Miller's Pyramid. Miller was a sort of a bigwig in medical education and decided that the way that we were doing most of our assessment and evaluation of medical learners was down here at the bottom of this pyramid, which is about knowing things. So just watching them do, not watching them, but evaluating them with things like testing, but not really anything else other than they finished their rotation. And the idea that Miller had is that learning actually progresses up this pyramid as they progress through their training. So maybe medical students, you might still focus a little bit on the knows and the knows how, but by the time they're residents, they really should be getting past the shows where they do simulations and OSCEs, and most of their residency training should focus on this idea of direct observation or workplace-based assessment. And so focusing less on anything below on the pyramid and trying to focus most of your efforts and time and energy as a program on watching them do things and giving them feedback. So I mentioned before something about an entrustment scale, and in the CBME literature, competency-based medical education literature out of Canada, they did some studies on what rating skills were felt to be the most objective and to give to correlate best with how residents actually performed in other areas. And they found this entrustment scale to work best. And so ABFM has asked us to start incorporating this into the work we do as a task force. And so I'm passing this on to you as you're updating any of your assessment forms now, you might think of just changing your rating scale to this. This is most useful if you're watching them do something. And because it's really not a Likert scale, it's not about how well you thought they did something. It's about how much help they needed. Did they really just have to shadow you doing it? We think about this a lot with procedures, uh, but it really, any skill that they're demonstrating, whether it be taking a history, doing a physical exam, coming up with an assessment plan, giving instructions, whatever, how much help did they actually need? How much supervision or assistance? And then that allows us to watch how they progress through residency towards independence. Feedback with direct observation ideally should be completed in the moment. If you're anything like me, when I'm precepting by the end of the day, I've already forgot half of what I saw, especially if it's been a really busy day with, and everybody seemed to have a complicated diabetic patient. I sometimes can't remember which patient and which resident matched up. And so anytime we can give feedback in the moment and having tools that can do that is ideal. Combining it with teaching, as we said, making sure that we include the resident's perspective. The ADAPT model is one of those feedback models that does that. Oftentimes, if you ask the resident how they think when things went, they'll actually know what went. And so then you can just help them. You don't have to actually give them any bad news because they recognized it for themselves. And if they don't recognize it at all, that's also helpful information that they don't have the insight you want them to have. And the big difference to what we're trying to think about today, as opposed to what you did with your last session, is how to document this, which is challenging. So direct observation opportunities where you can document or when you can at least do it. So procedures, I'm guessing that you watch lots of procedures already, one-to-one, and give feedback about that. Simulations, including things like ACLS or NRP or any OSCEs that you might do during orientation or otherwise. Those are great, but they're not true workplace-based assessment. So workplace-based is actually with real patients and all those complexities that insert themselves when you're seeing a real patient. You may do like a half day where faculty shadows a resident, but that's very time and resource intensive. And so it's hard to do very many of those. And so what we're recommending is that you do snapshots where the preceptor who's already assigned just goes in for 5 minutes and watches the initial history gathering or part of a physical exam. The clinical reasoning, they can work through that with something like a SNAPS model of precepting in the preceptor room, and you're observing them doing that in a structured way. Going back after precepting when you are trying to do billing for a 99214 and you watch 5 minutes of counseling. So these are meant to be 5 minute or less snapshots, and then finding ways to just document that. The idea being that you can do a lot of these over time, and it becomes much more meaningful than just one point in time where you watch all of these on one encounter. So the challenges of trying to do direct observation in real residency programs, as opposed to just this idea that the people who don't still do the work day to day, is time. And so I think the more that we can make this routine and build it into precepting with the snapshot model, which really means training our faculty and our residents to accept that kind of feedback and to think of ways to do it efficiently so it becomes an expectation. Another big challenge are when we have struggling learners and you just feel overwhelmed by the potential feedback you might give them. And so I would recommend that you really just focus on one or two constructive comments at a time. You don't have to cover everything because it can be overwhelming for them. And of course, focusing on things that affect patient safety first. Attitudes from both the faculty and the residents. But I think that sometimes you get a little pushback from a resident because they're like, oh, well, the last attending told me to do it this way, and now you're telling me to do it that way. And that is frustrating. And even though it's annoying to us, it's frustrating to them too. So it's okay to just say, when you're working with me, I want you to have different perspectives, but when you're working with me, I'd like to see you do it this way. Other resistance from residents that you might try to figure out why is they just have a fixed mindset. They just really aren't interested in talking about new ways to do things. And so that's a culture change. One way to get past that sometimes is the old motivational interviewing technique that we do with our patients. It works great on your adolescents, I can tell you, from doing a lot of adolescent medicine these years. And it works great on your residents, which I find a lot of similarities sometimes. But in a good way. They're both some of my favorite people. So recommendations for direct observations: train the observers on how to do it, make sure that we have that shared mental model. Select observers based on the skills and expertise that they have. Not everyone is probably going to be able to use more complicated tools. It may just be your core faculty. Really, if you don't have a culture that accepts feedback well and has a growth mindset and finds it useful, then it's probably not going to be successful. So start there. Pay attention to system factors like how things are scheduled in order to embed direct observation opportunities. The more of these you can get with multiple people over time, the more useful they'll be. And then the more longitudinally that they're done and they build on each other, then that integration of feedback can be done so that the residents have the opportunity to improve, because there's nothing worse than finding out you were doing something wrong at the end of a rotation when you probably could have gotten that feedback on day one in a structured way, and then followed that up so that by the end of the rotation, that had been taken care of. So it sounds like most of you, if not all, are using new innovations, so we won't go into that again. But what I would like to do now is walk you through a new tool that's built into new innovations, both on the web-based version and on the mobile app. Does everybody here have the New Innovations mobile app downloaded on their phone? So I would highly encourage you to do that because then you can access that version of this, and it's really programs that in the pilot and other programs have been using this are using it really successfully. So I think that you'll have a good experience once you get used to it, but we'll just talk about what it looks like. So if you do have the New Innovations mobile app, or when you do, this is what the home screen looks like. And so you think to yourself, oh, I'm going to click on direct observation to get to the form. Well, that won't work. You have to click on evaluations. If you click on the direct observation, that takes you to a form that was developed for other residency programs, and it's not what you're looking for. So you would start on this homepage and click on evaluations. And then you go to the next page, and it looks like this on the phone. And you would have to choose whether or not you want to do a new evaluation as the evaluator, or does the resident want to request one of these done? One of the things that some programs are doing is they're giving incentives for the residents who reach a certain threshold, so that they're the ones that are asking for these. So either the resident or the evaluator can request it, but in general, it works better if the evaluator initiates it, so you don't have to wait for it to come to you to do. And then once you click on, if you go back here, once you click on new evaluation, it would take you to this. And then you would see the different residents in order here. And they're in alphabetical order by their last name by default. And the different evaluations are also in alphabetical order. So if you clicked on active assessment using direct observation, then which is that's why it's named active assessment, is because those two A's come to the top, and it'll always be at the top of the list for new innovations users. Then it would take you to this page. And On this page, I've over to the left, I've put just blown up colored versions of what we're looking at over here in question number 1. So this is where, if you could, either you can go into New Innovations and find this, or just click on the PDF version that's in the chat and follow along with me if you can. So I'll give you a second to do that. Does everybody have it? Just a thumbs up if you do. Okay.
And I just posted it to the chat again. I know a couple people joined after
Oh,
the
thank
first post.
Okay, so the PDF version is what it looks like on your desktop, but it actually mirrors almost exactly what it looks like on the phone. It's just on the phone, it's a miniature version that's made to fit the screen. So when you would go in and see a patient with a resident, if the reason there's a star by the number 1 is because you have to answer this question, because everything after this question will flow into one of those topics. And so one thing that comes up a lot is most of your resident patients don't see somebody for just one thing, right? They've got an OB patient with an acute illness and musculoskeletal knee pain, and they're only 16, so they're pediatric, right? And that tends to be family medicine patients, especially in residency programs. But just pick the one that's most related to either the chief complaint or the one that you observed, especially if you're only doing a snapshot. You probably only observed one part of this, so but you only pick one. And then after that, and then again, the reason that this is important is that when you're generating reports later, this will send all the rest of the questions to a particular outcome, so you can make outcomes reports. This is how those questions are mapping to the outcomes. Like if you answered the question on diagnose and manage acute illness and injury for all people, then that outcome would map to anything that if you chose acute illness on the first question. So then the next question is the clinical complexity. And you don't have to answer this, but if you do answer this whenever you use the assessment form, then it again gives your clinical competency committee a little bit extra information for how complex the patients are that each resident's seeing. Because if a resident's needing more help than a different resident, but all their patients are more complex, then that's actually helpful to know why that they may be needing more supervision than other residents who are seeing less complex patients. So it looks like that over there, and it's clinical complexity, not billing complexity. And then the next, these are all the question headings in questions 3 through 11. So there's a question about communication, effective data gathering. It's meant to be sort of in the order of what a visit might be, just so it would be more intuitive. And so when you're seeing part of a patient, part of an encounter with a resident, you only have to pick what you saw. So if you only watch the physical exam, you can just scroll right by the rest of those questions. It's not an app where if you choose one, it kind of turns the page and you have to wait for it. It's actually just scrolls it, and you're not, you can close it without answering all the questions. So you only answer the ones that are applicable to what you actually observed. And then you can say you picked the one that was communication. The full version of that says communication with patient, and it gives you a little bit of a hint what that means: respectful verbal and nonverbal communication, using appropriate language, building rapport and trust. And then you can see there's this entrustment scale below that. So you would check how much help that they needed. Did they do it completely independently without assistance, or did you have to weigh in a little bit, or did you have to weigh in a lot, or did you have to take the visit over? And so that's where that comes from. And then if you want to see where that maps to subcompetencies, this is just more for reference. For instance, question 3, depending on how that's going to send information back to interpersonal communication skills number 1 on when you're doing your subcompetencies. All this happens, you don't have to map any of this. It was done for you by New Innovations behind the scenes. So then after you get through those questions 3 through 11, whichever ones you decided to answer, then you get to this, and this is where you give your narrative comments. And I know you talked a lot about good narrative comments in the last faculty development. And so we give you some prompts here as well. Summarize what the resident did well and what could be improved for next time. Discuss your observation, I observed, etc. And this can be done with voice to text, especially if you're using your phone. If you're using a desktop app, then typing it in is not such a big deal. And you don't have to answer all of these either. Just answer the ones you think are going to be the most useful. And it's meant to be useful. This is meant to be a useful tool so that you can truly use it in the middle of the day and be as robust or as minimalist as you need to be just to get through your time so that you can get a lot of these filled out over time. All right, so now what I'd like for you to do is practice using that form you have. And so I'm trying to figure out how best to do this. If you're actually in the same room, you can pair up with someone directly. Otherwise, we could put people in a breakout room so that you can do it together. How's this best going to work? I don't know where everybody is right now.
So I see 3 people from the same program. I think 2 people right from the Alamogordo, and then 1 from HMS. Do you think it'd be better to group the people in the same program?
Yeah, I think that would be great. And then if there's an odd person out, maybe we could put them in a breakout room with the program that has 3 people. Would that work? But not quite yet. We don't want to break out yet. I just wanted to be thinking through it. And then before we do that, I'm going to have you watch this video. And the idea as you're watching the video is to take notes on your assessment form, or you can just jot down notes if you're only looking at the electronic version, and be thinking through, okay, if I was watching this visit, what feedback would I give to this person? And then we're going to practice doing it on your partner after the video is over. So right now you're just going to watch a resident doing a visit, and you're going to be thinking about if you were actually watching them while precepting, what kind of feedback would they need? Does that make sense? Okay, I'm going to start the video now.
Hello.
Hi, nice to see you again.
It's been a few months since we've seen each other, and I see in your chart you've been having some swelling in your legs. What have you noticed?
Well, yeah, I've had some swelling and it's really uncomfortable.
Both legs?
Yes.
When did it start?
Well, it started gradually over 3 to 4 months ago. I know I didn't have it when I last saw you, but if I did, it wasn't bothering me. If it is now.
And when is the swelling worse? Morning, evening?
Not so bad in the morning, but it gets worse as the day goes on. And if I'm on my feet all day, I can hardly walk.
Any changes in your breathing?
No, I get short of breath if I move around too quickly.
How about shortness of breath waking you up from sleeping?
No.
And what about needing to prop yourself up on pillows to breathe at night?
I sleep on 2 pillows normally, just because it's good for my back and my neck.
No chest pain or pressure?
No.
No abdominal pain?
No.
Changes in urination? How about feeling cold when others are hot?
Well, I'm warm all the time. Still doing
No new constipation, changes in your hair, skin, or nails?
I've got some constipation, but stool softener, milk of magnesia, they usually do the trick. What was the other thing you asked me?
Changes in your hair, skin, or nails?
Oh, no.
Any changes in your medications?
Well, you changed my insulin the last time I saw you.
Looks like you're on metformin, 1,000 milligrams twice a day, glargine, 26 units at night, aspirin insulin, 4 units at breakfast, 6 at lunch, 6 at dinner, hydrochlorothiazide, lisinopril, amlodipine, pravastatin, omeprazole is needed, and ibuprofen is needed. How often do you take the ibuprofen?
Well, lately my back's been bothering me, so I've been taking it twice a day.
Looks like we increased your amlodipine dose about 6 months ago.
Yeah, you mentioned you felt like my pressure was too much.
Right. Anything you've tried to help with the swelling in the legs, like keeping them up? Are you using a lot of salt?
No, you talked to me about that, so I know you gave me that list of foods to avoid, so I've been avoiding those foods. So, every once in a while.
Any tobacco use?
No.
And I ask everyone this, how often do you drink alcohol?
On occasion, special occasions, birthday or anniversary. You know, about my legs, it starts like right down here, and then it goes all the way up in here. And there are times when my legs get so swollen, they feel achy and they get tight. With the weight, the diabetes, the pressure, my back, all of this, it just feels like I'm falling apart. Nothing's getting better. I'm taking all this medication. I just wish that I could feel it.
Well, unfortunately, some of this comes with age and lifestyle. So let's see if we can figure out this swelling.
But you mentioned chest pain. Do you think I might have a heart problem?
Well, anyone in your family have heart problems?
Well, yes.
Oh, I see your mom had some heart disease. I think we're just going to have to wait and see. I'll still have to examine you and we'll run some tests. I also wanted to follow up on your diabetes. Last time I saw you, we increased your glargine insulin to 26 units at night, and you were going to increase the insulin before each meal to 4 units before breakfast, 6 before lunch, and 6 before dinner. Have you been checking your sugars?
Yeah, sometimes.
Can I see your log?
I forgot the log. I left it. But I do, check my blood sugar, and so I get early in the day. It's maybe 120, 30, sometimes 150, and then it gets a little higher later in the day, 180, 203 or 230. I guess, and then at lunchtime, it's
Any lows?
no.
And your diet?
It's about the same. I rarely have breakfast, maybe a slice of toast, and then I have my lunch with everything.
And what about dinner?
Husband and I have dinner together. We usually have chicken with vegetables or either rice or potatoes.
Do you miss any of your insulin doses?
If I don't eat breakfast. But otherwise, I do my dinner and before bed.
How about lunch?
Well, if I go out to lunch, I don't take it with me.
Okay. Any other questions before I examine you and see what's going on?
All right, so one of the reasons I show you this is just the idea that I imagine if this resident came in and precepted that they really did ask a lot of questions that you might think they did a great job and that was a great visit. But if you watch, you might come to a different conclusion. And so the power of direct observation is that there are things that cannot be assessed unless they are observed. And I think this is one example of that. And then, so the next thing, the reason the practice thing is not because you need practice giving feedback. I just want you to be able to see how much information you can actually give in 1 minute to someone. And about, like, if you came in, this was 5 minutes, watch this 5 minutes, what could you tell that resident in 1 minute that might be meaningful? So let's try that with your partner, and I'll time you and see if you think that that would be useful to you in your own precepting. All right, I think everybody's back. So I just wanted to invite comments about that. How you think using something like that as an app or immediately going back to precepting and doing it on the desktop, do you think it would be useful to you? And could it be done efficiently? Like, could you do one per week per resident if you worked towards that, for instance?
So I wasn't logged in on the app, but I think we definitely could make some observations that could be translated into some of those sub-competencies, right? Like communication skills. Because I think that's really where the focus would be, right?
Yeah, I think so.
I think it really brought forth that I should be doing this more, because sometimes you get patient complaints or, and it's like, but they're doing a good job taking care of you. But if this is what happens in the room and we're just blissfully unaware, right?
Right.
That's not good. So I think more of those, just kind of taking the time to go in and actually watch the whole encounter and see how that resident is actually interacting with the patients, would be, and then do it for everybody. I mean, don't just like pull certain people out, but because sometimes patients will just say, I want to change. I don't like that resident, but they don't really elaborate. And you can see why something like this could cause that, right? Like there's nothing you can really point your finger on. It's just, she didn't really listen, She just wanted to get everything documented and get out of the room. And that didn't feel very good.
And I like what you said about doing it on everybody, because I think then residents don't feel targeted. Like, oh, we're just going to observe you. Just observation is part of residency, and getting that feedback is part of it, and it's just built in, and so it's more accepted, I think, that way. Any other comments about the utility of doing this realistically in your program?
We talked a little bit about the tool. We had played with it some before, and maybe this is just an assumption I made, but I was like, how could you fill this out quickly? This is so comprehensive. This is useless. So thank you for pointing out that you don't have to fill the whole thing out. Like, duh, that's so helpful. So I'm like, oh yeah, this is actually really helpful if you view it that way.
Excellent. Yeah, and isn't that the truth though? So many of the things that we are asked to do or are doing, if we don't have faculty development and resident development about how to do it in the way that works best for your program, then people just don't use it at all. It's just we're all that way. Yeah. All right. So I'm going to kind of just go through the last thing is the reporting. So this again, because you have the access to the slides, will just allow you to know, okay, now wait a minute, where is this, when the CCC looks at this, how is this all going to relate to each other? So there's no need for you to know this now, but it's just more for a reference. And I had New Innovations send this to me so that you would have access to it. And the sub-competencies as well. And then just when you do go into the report, you know how like you do your milestones reports in New Innovations, does everybody do that? Then this is, instead of going to the milestones, you'd go to, there's a new button now on that page that says Family Medicine Core Outcomes. And when you click on that button, then it looks like this below. And say you want to look at outcome number 3, if you just click on the dark blue part of outcome number 3, then this drop down below it comes up, and you can see here, and it reminds you what outcome 3 actually is. And then over to the side, this is all the times that your program would have looked at outcome number 3 or looked at the questions that are related to that. And so here it shows the questions that were related to that. Looks like this faculty, and this is one from our program actually, this faculty was looking at a physical exam on a pediatric patient, and she noted that they needed required minimal faculty assistance. And then if they had done this, if 10 faculty had observed physical exams in a pediatric patient, they would all be here, and it would be in chronological order, so you could see if they were improving or not. Because I don't know about you, but sometimes it's old news. What they were doing 6 months ago, maybe they're not doing it now. So being able to see that change is really important. And then down here, the same faculty watched them. It could have been the same encounter. It looks like it was. They were both on July 9th. So we know that the M means that it was moderate complexity. And then she did the voice to text in the feedback portion at the bottom. And so that it shows up here. So this is what your clinical competency committee will be able to see based on the outcomes. So for resident A, you can click on any of these outcomes. I clicked on outcome number 3 to show you what a report looked like. Shows you outcome 3, shows you all the questions that were related to that particular outcome in chronological order, and then gives you how much supervision they need with their comments. So just and there's information within New Innovations medical knowledge. And don't worry, trust me, New Innovations doesn't pay me for anything. I only wish they would. But MedHub does something similar, but honestly, they just didn't spend as much time putting theirs together. But they do have the same form. The reporting just isn't as good. And I think that is it today. So hopefully you feel like you can access that toolkit, and that you can integrate direct observation into your workflow a little bit easier now, and that you will make use of that report, knowing what it actually does and have the resources to utilize that. So we have just a few minutes if there's anybody that has questions. I know I ran over a little bit, and I apologize for that. But if there's, you can always email me, and Amanda can make sure you have my email address. And I'd love to support you in your journey to competency-based medical education. And every question you ask me helps me know how to help somebody else, including my own faculty. So thank you so much.
Thank you so much, Dr. Wright. I really appreciate you so much, and great presentations. Hopefully people could pull from the resources and tools as well. We do have a few, Dr. Wright will be joining us again for CBME Part 2 in November, so looking forward to that, and on the first Wednesdays of the month. So look out for that, and thank you guys for joining.
Thank you, Amanda.